The concept of mental health and psychosocial support is that they are complementary elements of one structure where it looks at promoting and protecting people's well-being and anything that might prevent or treat mental disorder. And that's an agreed definition or an agreed term that's been recognised by international guidelines. The humanitarian imperative is to save lives and reduce suffering. And so in a humanitarian crisis, there are always people who were suffering from mental health conditions or psychosocial disabilities before the crisis occurred, or some that will experience these things more after the crisis. And so the link between mental health and psychosocial support and trying to reduce suffering, whether people are on any end of that suffering spectrum, is part of our imperative. So it goes hand in hand with humanitarian response.
There are many reasons to prioritise mental health and psychosocial support in emergencies. There's a subgroup of people in emergencies that have psychosocial disabilities, and they particularly are easily excluded from emergency responses. They need to be included, and they need to be protected. We know many case examples of people with psychosocial disabilities not getting core humanitarian aid, or not it has happened that they didn't understand instructions by security personnel and got killed. In many countries, there are institutions. We wish they weren't there, but they are there. And these institutions, often called mental hospitals, there are many people with psychosocial disabilities. And we know various scenarios in rich and in poor countries where in emergencies these institutions were abandoned, and the people in there were neglected and sometimes hurt, raped, killed. In addition, emergencies are full of extreme stressors, and they can be a risk factor for a range of mental health problems. And again, if our humanitarian imperative is to reduce suffering, we should try to address this.
The rationale for doing more is that I think it's understated in nearly every country of the world how much of a difficulty mental health and psychosocial support difficulties are for people. We know that it is common in every society, and it's particularly more common in countries where there has been poverty or consistent conflict or other elements of humanitarian crisis. So in those places, the suffering is much greater. And that gives us a drive and a need to actually do more and address it.
It's extremely important to do more and to do better. And that's because the reality is that right now, the vast majority of people do not get any mental health, psychosocial support. So that's the rationale for doing more. Second point is that too often when people get mental health and psychosocial support, the quality is not there. Quality needs to be good enough to make it worth it. Otherwise, it's better not to intervene.
We need to do things better and do things well so that we don't cause harm. Some of the challenges around mental health and psychosocial support practices have been known to cause harm in the past, and in the future we want to do good practice and practice that we know is based on evidence and practice that we know makes a difference. When people ask which mental health and psychosocial support interventions are the most promising, people are often looking for a one-solution answer. And the truth is, there will not be one solution answer because the needs differ for different people, different ages, different gender, different contexts. What we know, the best humanitarian mental health and psychosocial support responses are those that incorporate all elements of ensuring people have access to basic needs, ensuring people's safety and security, ensuring people have the opportunity to be part of family, community, included in society, and that there are supports for people who might need more specialised care. and that specialised care is done in ways that do not violate their rights and in ways that keep them safe and improve their functioning and well-being over time. So there's no one answer to say that there is one thing that's best practice, but what we know is ensuring all those aspects are available to individuals, families and communities is what's going to make the ultimate difference.
In emergencies and after emergencies, there's numerous priorities. And you may be listening and thinking, well, you know, is this also a priority? So the reality is that when one adds mental health and psychosocial support to other programming, let's say to health or to protection or education programming, that one is able to make those programs a greater success. So one can integrate mental health and psychosocial programming in livelihoods programming, in schools, in programs for HIV/AIDS, programs for non-communicable diseases, and that will enhance the quality of this programming. And for example, I work for a health agency, so I give a health example. A key issue in healthcare is adherence. So the care for HIV and for TB involves a medical approach which requires an adherence to the prescribed medicines. Now, when people have struggle mentally, it can be more difficult to adhere to such requests of taking one's medicines regularly. What it's found is that people who are much more distressed and more depressed, they actually die. The rate of dying from tuberculosis, from TB, is much higher because they are less adherent to the prescribed regime. So it's in the interest of health programming, and similar for school programming, for livelihoods programming, to include the mental health and psychosocial support component to make their objectives more likely achievable.
Some people think that to do mental health and psychosocial support programming, you need to have extremely high technical capacity to be able to deliver it. And that's not necessarily true depending on the interventions that you're actually implementing. So it is possible to still have psychosocial support impacts on a community or in a children's program with people who are doing good quality programming and not necessarily mental health specialists. There would be times when technical specialty is required or technical supervision is required, but that's not essential for every kind of mental health and psychosocial support program. So having the right technical capacity to match the right kind of program is an important consideration, rather than just saying we can't do any mental health and psychosocial support because we have no technical capacity. That's not quite the message that we would send out.
You may be listening and thinking, well, where do I go next? What if I want to learn more? What if I want to get advice? We at WHO, one of our roles is to give advice, so we would be very happy to give advice. In addition to that, there is a group which has an unusual name. It's called the Interagency Standing Committee Reference Group for Mental Health and Psychosocial Support.
People who are interested in doing mental health and psychosocial support programming would be best to have their starting place at the Interagency Standing Committee guidelines on mental health and psychosocial support in emergencies. That's freely available and downloadable, and there are many supplementary resources to help people interpret and operationalise those guidelines. And there is an international reference group called the Interagency Standing Committee Reference Group for Mental Health and Psychosocial Support. And part of their remit, part of their mandate is actually to support people in humanitarian contexts to do better mental health and psychosocial support programming and coordination amongst different groups. So there are many resources, but the main one would be the international guidelines, and then the people resources is the global reference group that supports the dissemination of those guidelines.